This is the second of a three-part video series on the anterior and medial thigh. You will want to watch the first part, the bony thigh anatomy, before watching this one, which covers the musculature and the innervation of the anterior thigh. The thigh is enclosed by a thick layer of deep fascia called the fascia lata. It forms the outer limit of the fascial compartments of the thigh, which are internally separated by intermuscular septa, formed by indwellings of this fascia lata. The fascia lata is thickened at its lateral side, where it forms the iliotibial band or iliotibial tract, a structure that runs to the tibia and serves as the site of muscle attachment. Superficial veins are located in this superficial fascia and normally send blood to deep veins via perforating veins. The dorsal venous arch of the foot gives rise to the great saphenous vein on the medial leg, the posterior medial knee, and then the medial or anterior medial thigh before it dumps into the femoral vein at this location through this gap in the fascia lata called the saphenous ring. Here we can see that saphenous ring. This dorsal venous arch also gives rise laterally and then posterior in the leg to the small saphenous vein. The small saphenous vein courses up the posterior leg through this region posteriorly called the popliteal fossa and then contributes to a deeper vein called the femoral vein, again as it rises up, and then receives the tributary of the great saphenous vein. The deep fascia of the thigh and the leg, in the thigh again called the fascia lata, and in the leg called the crural fascia, they have other specializations. Again, we saw one specialization as this iliotibial band. Also, laterally, you'll note that this iliotibial band shows some expansions anteriorly. This is called a lateral retinaculum at the knee, and this has small connective fibers from the iliotibial band that connect into the patella. We'll also see when we get down into the leg that we'll have some other retinacula, extensor retinacula, and some flexor retinacula that I can't really draw in this region there. So again, these are specializations of this deep fascia called the fascia lata, or in the leg called the crural fascia. It helps to break down the limb structures into its various compartments, which will help hone in on the muscles of those compartments, innervation, blood supply, and general function. While the arm and the forearm each have 2 compartments, in the thigh and the leg, they each have 3. Now we can see how the deep fascia of the thigh, or the fascia lata, separates the thigh via its indwellings of intermuscular septa. So here we can see the fascia lata shown in the green dotted line surrounding the anterior compartment, extending into the blue line surrounding the posterior compartment, then the orange line surrounding the medial compartment, and then the indwellings of the fascia lata forming the various intermuscular septa separating the 3 compartments. Here we see the anterior compartment is innervated by the femoral nerve. Its primary blood supply is the femoral artery, and its primary functions are, if the muscles cross the hip, are to flex the hip, and for the muscles that cross the knee is to extend the knee. Over in the medial compartment that we'll see today, the medial compartment is served primarily by the obturator nerve, although one muscle may be also innervated by the femoral nerve. The primary blood supply is the obturator artery, although it gets help from the femoral artery and another artery called the deep femoral artery. And its primary function is to adduct the hip, at least within the anatomic position. Its function would be to adduct the hip. The muscles in the posterior compartment are mostly innervated by the tibial nerve, but there is one muscle that gets innervated by the common fibular nerve. The primary blood supply is this deep femoral artery, and its function generally is to flex the knee or extend the hip if those muscles cross the hip. Here we can see the origins of the femoral nerve serving the anterior compartment of the thigh, as well as the obturator nerve serving the medial compartment of the thigh. Now, please don't have flashbacks to the brachial plexus when you look at this. All I want you to appreciate from this is the following. The anterior compartment is served by the femoral nerve, and the femoral nerve comes from L2, L3, and L4. So here's the femoral nerve, and as we trace it back, we can see its origins from L2 through L4. The same is true from the obturator nerve. It's also served by L2, L3, and L4. So that's pretty easy. The last take home from this slide is regarding the lateral femoral cutaneous nerve, or seen here as the lateral cutaneous nerve of the thigh. This comes from L2 and 3, and that's going to become important when we look at the dermatomal distribution of this lateral femoral cutaneous nerve as it distributes itself down here in the lateral thigh. The anterior compartment of the thigh contains 7 muscles that act on the hip and or at the knee joint. 4 of those muscles are included in the quadriceps, plus 3 others. Iliopsoas, i.e. the iliacus, and the psoas major act on the hip joint only. Sartorius, here we can see sartorius plus its origin point up here, plus rectus femoris, act on both the hip and the knee joints. The vastus muscles act on the knee joint only. On the right, we see 2 muscles that emanate from the retroperitoneal space in the abdomen. Coming off of T12 and then L1 through L4 is the psoas major muscle. Because it originates from the lumbar spine, it could also act to help move the lumbar spine or increase lumbar lordosis. But its primary action, along with the iliacus, which emanates from the iliac fossa, is to provide flexion of the hip. Here we can see active flexion of the hip. Now note this psoas major merges with iliacus to form a single muscle here in the leg called the iliopsoas muscle. The bulk of the anterior compartment is made up of the quadriceps muscles. These 4 muscles are all innervated by the femoral nerve. Most anteriorly, the rectus femoris is the only muscle of the quadriceps, in other words, of these 4, which cross both the hip and the knee joints. It arises from the anterior inferior iliac spine of the pelvis, just under the ASIS, or anterior superior iliac spine, spans the length of the femur and contributes to the common extensor tendon of the quadriceps, which inserts into the patella and ultimately inserts onto the tibial tuberosity via a patellar ligament. Recall that the patella helps to enhance the mechanics or torque that the quadriceps apply at the knee to extend it. The other 3 muscles of the quadriceps are the vastus medialis, the vastus lateralis, and underneath this rectus femoris, if we pull this rectus femoris away, we see that there is another muscle called the vastus intermedius. Again, here we have the medialis, the lateralis, and then the intermedius. All 3 vastus muscles originate from the femur and then extend down, contribute again to this common quadriceps tendon through the patella, through the patellar ligament, and into this tibial tuberosity. So in summary, the rectus femoris flexes the hip, extends the knee, while the vastus muscles only extend the knee. The sartorius muscle in the anterior compartment of the thigh has several distinctions. First, it is the longest muscle in the body extending from the pelvis down to the tibia. It is named for a position that a tailor classically sits in to work on garments. Note the tailor's position of hip abduction or abduction, hip flexion, and lateral rotation or external rotation. The sartorius arises from the anterior superior iliac spine, or ASIS, and courses inferiorly and medially across the anterior thigh, inserting onto the medial tibia via a tendinous structure called the pes anserinus or pes anserinus, named because it looks like a goose's foot. This goose's foot is contributed by three muscles. First, of course, the sartorius from the anterior compartment. From the medial compartment, we'll see in a minute the gracilis muscle, and most posteriorly from the posterior compartment, the semitendinosus muscle. With the muscles in place, we can appreciate a structure called the femoral triangle, which has a number of important structures within it. Let's first take a look at the boundaries of this triangle. The triangle's outer boundary is the medial portion of sartorius. The triangle's superior boundary is the inguinal ligament, while the medial border of the triangle is the medial margin of this muscle right here. This is called the adductor longus muscle, which we'll see when we look at the medial compartment of the thigh in the next video in the series. While hard to appreciate in this picture, if we turn our attention over to the picture on the right, we can appreciate that the roof of the triangle would be the fascia lata. In the floor is made up of several muscles. The floor is made up of the iliopsoas muscle, which is hard to appreciate as the floor here, but we can see the psoas here and the iliacus, and of course it combines down in this region to be the iliopsoas muscle before it inserts onto the lesser trochanter. Also, we see a little bit of this muscle peeking through here. That's called the pectineus. That muscle is technically part of the medial compartment of the thigh, which we'll also see in a minute, as well as, again, the adductor longus muscle, serving as the floor. The apex of the triangle, down in this region, will be continuous with what's called the adductor canal that ultimately opens up into the popliteal fossa in the back of the thigh. We'll see that in a couple videos from now. The contents of the femoral triangle are critical. Here we can see a nerve running through, the femoral nerve, the femoral artery, the femoral vein, and we see some lymphatics. We can see that as well on this picture, where we can see a femoral nerve, again, a femoral artery, a vein, and a femoral ring here, which contains lymphatics. And again, we see it here. There are some mnemonics to help us remember that. From lateral to medial, we could say the mnemonic navel, and this would be nerve, artery, vein, empty space, and lymphatics. Or we can go with van from medial to lateral, vein, artery, nerve. For instance, vein, artery, and nerve. Now there are numerous clinical scenarios where this information or knowledge is useful. For instance, let's say you need to feel for a femoral pulse. Here in this upper right picture, you have an individual or a clinician palpating for the femoral pulse. How do you locate the femoral pulse? Well, if you palpate the ASIS and then the tubercle of the pubis, and you go at midway, your fingers will be right on that femoral pulse. So let's say you want to do a nerve block. You would feel for the femoral pulse, and then you would inject your anesthetic just lateral to the artery. Or if you wanted to put in some sort of central line and you needed to feel for the femoral vein, you would feel for the pulse and then just go immediately medial to that. Staying on this slide, I'd like to point out two other structures. I already mentioned the femoral ring. Here we can see the femoral ring containing basically nothing, but if we look on this picture over here, we can see that actually the femoral ring contains lymphatics. So the femoral ring is contained within a larger femoral sheath. And so what's in this sheath? Let's take a look at this picture, and we can see that the artery or femoral vein, and the lymphatics are all contained within the femoral sheath. However, the femoral nerve seen here is not within the femoral sheath. Speaking of lymphatics, let's take a look at the lymphatic system of the lower extremity. We're going to pare this down and make it very simple. Lymph generated in the lower extremity will be diverted towards the medial leg. So lymph in this area might be brought up this way. Lymph in the posterior region will still be brought medially. Once in the medial leg, lymph will travel superiorly into the anterior medial lymph nodes up in this region, into the superficial inguinal nodes, into the deep inguinal nodes, and then ultimately in the external iliac vessels. Now note, the path that it takes is basically following along the path of the long saphenous vein. So once again, as lymph is generated, let's say in the foot, it is brought up into these anterior medial nodes, brought up the course of the great saphenous vein. They enter into these superficial and ultimately into the deep inguinal nodes, into the external iliac vessels. Then it follows those external iliac vessels up into the common iliac, and then essentially travel along upwards until it's brought into the cisterna chyli in the abdomen. In the next few slides, we're going to take our newfound knowledge of the anterior thigh and apply it, take a look at some of the clinical conditions we may see. Here we can see a femoral hernia. Now remember, previously we've seen the condition called a inguinal hernia, and that could be a direct or indirect inguinal hernia. And that's typically protruding through the inguinal canal, either up in this region here called the deep inguinal ring, as it passes through the inguinal canal through the superficial inguinal ring, or a direct hernia as it goes right through Hasselbeck's triangle or the inguinal triangle. Instead, we're really talking about an area below as abdominal contents protrude from the abdomen down through connective tissue in this region, through the femoral sheath and femoral ring specifically, and then the abdominal contents protrude through that and then through the saphenous ring here to rest on the anterior thigh. Now this will be a little more lateral than an inguinal hernia typically, as if you recall, the inguinal hernia comes through here and then either rests usually in a male in the scrotal area, not so common in the female. Note, a femoral hernia is more common in a female, and that's because of the lack of herniation through the inguinal region, but instead the weakest spot for the female is going to go through into the leg and out the saphenous opening here. This condition is also more common in the elderly or older patients, and also those who have undergone inguinal hernia repairs where they have a mesh in place that is a very robust barrier, and then the path of least resistance then would be through these openings. There are many clinical issues or scenarios in and around the knee joint. We'll go over just a few of those here. On the left-hand side, we see a normal configuration, if you will. Here we see the quadriceps, vastus medialis, lateralis, rectus femoris, and underneath that, the vastus intermedius. All four giving off a common extensor or quadriceps tendon going into the patella, off which comes this patellar ligament. And we'll call it a ligament because it's attaching bone to bone. So while this patellar mechanism gives us many benefits, most of which it increases, again, the torque or increases the mechanics at which the quadriceps can pull on the tibia, several things can go wrong. Primarily, or the more common one, is something called patellar tendonitis, also known as jumper's knee. In patellar tendonitis, typically the tendon, as it's attaching off the patella, gets irritated. You can certainly see it here in the mid-substance of the ligament, but generally it's in the upper portion of the patellar ligament. And this condition is more common in those who have increased their sporting event, usually in one that involves a lot of jumping or a lot of high force activity, let's say extremely vigorous sprinting or leaping. It's usually common in basketball, volleyball, etc. Something a little different than that that's not listed on the screen is a condition called Osgood-Schlatter. I hope I can spell that. Osgood, that's two O's. Schlatter. Sorry for my German pronunciation. Osgood-Schlatter disease is typically down in this region, okay, because it involves the tibial tuberosity, where the tendon joins into the tibial tuberosity, and often there is a gap of bone, if you will, there, so a fragment of bone. And this is quite painful as well. Again, this also occurs with plenty of jumping, an increase in jumping. It's usually a little more in the younger population as they're going through their growth spurts in their young adolescent days. And patellar tendonitis is often in a slightly older population and even into the young adulthood. Moving laterally, we see what's called IT band syndrome or iliotibial band syndrome. So recall that the iliotibial band is a specialization of the fascia lata, extends down from these muscles and attaches into the anterolateral tibia via Gerdy's tubercle. Well, as this tendon crosses, we'll look here, as this tendon crosses the lateral condyle of the femur, when the person extends and flexes and extends and flexes and extends during running, this area of soft tissue can get highly irritated, and this can be quite painful, particularly during the end of a long run or even afterwards for quite a number of hours. So this is a running syndrome, as the name implies. This happens typically in the older population, meaning in the grown adults, while this happens in more of the younger population, but sometimes in young adults as well. The last condition I want to talk about here in the anterior thigh is called patellofemoral dysfunction. Because of either a malalignment in the femur tibia complex, or generally at the knee, or an unequal pull from the quadriceps, let's say the lateral quadriceps has a larger contraction than an underdeveloped vastus medialis, the patella may track, instead of tracking up and down, the patella may track more lateral than medial during quadriceps contraction. This will lead to patellar tracking issues, leading to cartilage wear and tear under the patella and on the anterior femur. We can get a sense if someone is at risk for patellofemoral dysfunction by looking at the angulation of their femur with respect to the tibia. We do this by measuring what's called a Q angle. Now the measurement isn't as important as the general concept. If we take essentially a line of the femur and we measure that with the line of the tibia, we can get a sense on how much genu valgum one has. Here we see a relatively normal alignment. I would actually say that this is a little too straight. We like to have a little valgum, but if we have over valgus or a hypergenu valgum deformity, this again causes some tracking issues where the patella rubs up against the lateral condyle of the femur, thus degrading some of the hyaline cartilage. Because this is a configuration issue, or at least that's what contributes ultimately to the rubbing of the patella, you can imagine that this is quite common in young females as their hips have started to widen a little bit and the alignment of their femur changes over the course of a few months during that growth spurt. This is the final slide for the second of 3 videos on the anterior medial thigh. Here we see the innervation of the anterior thigh. Again, nearly all the muscles of this anterior thigh are innervated by the femoral nerve. So the femoral nerve is coming down, coursing underneath the inguinal ligament before it expands out quickly into several muscles. Here we have sartorius, rectus femoris, vastus lateralis, vastus intermedius underneath rectus femoris, and vastus medialis. There's 5 of the 7. Here I'll draw in the 6th one over here. This is iliacus. And then number 7 is psoas, but psoas, which is over in this region, is actually innervated by branches of the lumbar plexus. So again, to summarize, 4 of the 7 muscles cross the hip joint. We have iliacus and psoas, which only cross the hip. We have rectus femoris and sartorius, which cross the hip and the knee. And then the vastus muscles which do not cross the hip, but only cross the knee joint.